Hello, I'm Robert Dempsey, Department of Neurological Surgery, and I'm going to give an update on the COVID-19 crisis, where we stand right now, which is approximately halfway through. I think this is a very important time, probably as important as when we first started these little meetings to try to explain what was going on, because I think we're all getting tired and we're only in the middle. I want to explain where we are regarding the middle of this crisis and what that means. I want to explain that there's both good and bad news at this time. A lot of the good news relates very much to the situation here in Wisconsin. But there's also financial news, some which is breaking only this afternoon, which needs to be explained or understood as well as we can at this time. So while I fully understand that there's a lot of uncertainty, my hope is to try to put that to rest, and some of it is perspective. The human race has been going through pandemics, epidemics, infections for millennia. And guess what? We are a healthcare system. We're good at this. This is extremely frightening if you're in Africa, if you're a fisherman, if you're working large crowds. We are in a very, very protected situation, and we are very good at this, and we will be good at this. And I think that's important. To begin to understand that, let's put this present situation in perspective. You can see why my biggest concerns are really the rest of the world. Right now, we're in, I think, the middle of a crisis because we have a novel virus. We don't really have an effective cure, but we do have treatments. And as we get further into it, we'll see some of the treatments have gotten better. We've passed the 3 million mark of cases worldwide and approximately 250,000 people dying worldwide. These numbers are grossly underestimates. Epidemiologists will look at this situation years from now and say, when we look at the data, we see the unexpected number of deaths, we'll see it was actually much more common. We'll also see that one of the reasons we got through it is people built up immunity, often without knowing it. These are all going on right now. As I told a week ago, the officials in Ecuador think they have 500 cases. The undertakers know they had 8,000. This is very, very common. In the United States, we number over 1 million cases now. That's 1/3 of the world's cases. So does that mean that we're the center of a transportation hub, east versus west, that we're very unlucky, that we test more and discover cases more? The answer is yes, all of those are true. But there certainly is a very large concentration in the US, but particularly at certain hotspots, with about 60,000 deaths. The situation in Wisconsin and Dane County is much better. 6,000 cases in Wisconsin, 300 deaths. In Dane County, only 400 cases and 22 deaths. And this is really important. I think furthermore, if you begin to look at the situation that we have here at our own hospital, you begin to understand that some very important lessons here. Our own hospital right now has seen a number of cases. Just to tell you what they look like, the average age is 62. So we definitely do see younger people, not just 80-year-olds. The average person who's sick enough to be hospitalized has risk factors. Those risk factors aren't necessarily asthma, but more likely those cardiovascular risk factors of hypertension, diabetes, strokes, and heart attacks that make them susceptible to the coagulopathies or thickening of blood that can occur with this disease, or to the stress that they cannot stand. And that may be one of the most important features that we're finding out. We know that 40% of the people that we admit here end up in the ICU. If you look at worldwide, the average figures look like about 50%, perhaps as many as that, may not have significant symptoms. About 15% are sick enough to seek help, and about 5% die worldwide. But once they're in the hospital, those that are sick enough, they die at a frightening rate worldwide. At least half of them are critical, and if they go on a ventilator, 80% of them die. The figures here are very different, and that may be for many things, but I think it has to do with we have facilities and ability to care for people and have learned about that. With things like prone ventilating, things like nasal oxygen, and some experimental things regarding plasma and drug treatments, we've cut the death rate here at this hospital considerably lower. Only 9% of our patients in this hospital have died, and 47% have already been discharged. This is extremely good. And indeed, we intubate less, and we're able to look at ventilation in different positions, which have been helpful. I think another thing that's important, since a lot of this audience are healthcare professionals and frontline professionals, to understand just what happens when your population socially isolates and you have effective personal protection equipment and you use it properly. Healthcare workers, that includes doctors, nurses, paramedics. In China, 3,000 died. In Italy, 10,000 died. In New York, we think that 27% of the healthcare workers have at least been infected. The situation in Wisconsin is extremely better. If we look at Wisconsin, the estimates that includes Milwaukee are 3% for healthcare workers. And if you look at the UW health system, our rate of infection in healthcare workers is 0.3%, meaning that many of these people simply got it in the community, not from the hospital. And when you begin to see that, that means that we're taking very good care here, and that's a team effort. In other words, the hospital does a very good job keeping the workers and the patients safe. If they come in without COVID, they get treated for their other medical problems, they're sent home without COVID. And the workers have been kept safe. What that means is that we're very good at this. And we need to understand that we means everybody. That means that includes the population who have isolated, who have followed the rules. So yes, this is an unnerving time as the world and the population tries to open up again. And there's several steps that would be very important for that opening up. One is significant testing so that we can say your patients, your not just operated patients, but also procedure patients, and I believe strongly clinic patients are tested, are not infected, are not infectious at this time. You're taking care of them. The news regarding that will be game-changing, even probably more than antibodies, which are still somewhat uncertain, even though we're going to try to test them in the next month. But to be able to say that your patients do or do not have the disease is really the important point. I've been making this point again and again and again to leadership, and I believe that in the short period of time, we'll be able to provide that care, which will be important for us to be able to assure safety. And that's important because if we can assure safety for our health workers and our patients, we can begin to expand the care we give. And that's really the next major point. Because UW has shown that it can provide safety, and because the state of Wisconsin has shown that they can protect each other, it is reasonable for us to begin to provide care for more urgent conditions rather than just emergent. Because I can assure you what's been going on is that people have not been going to their doctors and clinics to get their breast scans. They have not been having their preventive care for their diabetes or hypertension. We see that on neurosurgery with the increase in strokes. Not only does this disease cause people to become hypercoagulable, dehydrated, and have a stroke, but also they're frightened, they don't go to their clinics, they don't get their hypertensive treated, they have hemorrhagic strokes. This playing out in every branch of medicine is not healthy. So what we need to do is to provide that care that keeps our population healthy in a safe fashion. And so that's what we're doing really in this past week, beginning to expand our OR services to things such as slow-growing tumors or prevention for stroke as opposed to intervention during a stroke, because we've been seeing these people coming too late. and we want to stop that by reopening. Very carefully, very gradually, in a process that will probably take weeks and months. But we've seen that the TAC hospital opened 2 days ago. The UW hospital over the last 8 days have increased the operations being done. They've gone to 6 days a week operating until 7 o'clock at night, and are beginning now to expand the radiology, pathology, monitoring that we need to do that, and that's very important. I believe that our postponed patients can be spread out over many weeks to gradually begin to catch up on those by looking at who's sickest first and going in that fashion. But it's equally important that we open our clinics as well, because people need to go to see their doctors and be assured they're safe. One of the programs I'm hoping we'll be able to figure out is a way for them to safely bring a one person with them who can take notes, who can be them with them during their hospitalization, who can decrease the fear which so many have. Because that gradual reopening is essential for ours to provide the health care that we wish to this society. And to do that, we have to make sure that it's safe, and that means both testing, and if we can do it properly, antibody testing. Right now, the actual testing for people who are infected is by far the more effective way to go. We hope antibodies will in the near future. So it's important also to understand something that's important to all of us who are working. Many of our families, many of our friends are not working, and our farmers are not planting crops. This is a very, very serious situation in the United States, but it is devastating worldwide. The concerns about famine for Africa, Central America are very real if people are not able to safely get past this. And therefore, this idea of learning a different way to go about our society where we can provide essential services which include food safely will be the lessons learned. I think that we're all very restless. We're all very pushing back. And today we heard that the university, which suffered approximately a $100 million loss, is beginning to furlough people. It's important to put that into context. In the last 8 weeks, our system, health and education, has lost approximately $500 million. It's impossible to make payroll at that point. Yet we need to keep the doors open. So all of us have been asked to take a decrease of some sort or another. We have talked in the last weeks about, especially at the faculty, but also at the staff, the nursing, the APP level, that there are reductions in salary, which are attempts to keep the doors open and keep people working. The people that are based with the university were waiting, and quite expectedly, there are cuts at that point. What the university does is a furlough system, where for days, spread out over months, people are asked not to come to work and not be paid for that day. It's very important to understand, because so many of us are split between the two systems, that the dean is very committed to not allowing people to be doubly penalized. In other words, through a very complicated system we're going to have to work out, as soon as we see what the furloughs are, we will try to be fair to everyone, spread this out. And that's really one of the next important things. We are all in this together. We are a team, and that team must be held together, because we need to reopen the care we give. We're not making widgets, we're taking care of sick people. And that's what a pandemic is. And the additional elements are that is that we have to take care of people's hearts, we have to take care of new babies, we have to take care of strokes, we have to take care of cancer. And to do that, we need the team, which is everybody. So it's maybe a time that's fearful, but it's important for us to slow down and be patient, as with this recovery, I truly believe will take many months, but we'll all be better for it. I talked about my own family, how my parents went through the 1918 pandemic, the diphtheria epidemics, the polio epidemics. We're phenomenally better people for that. We as a society have taken the top off of this pandemic. That's to say, we could have had 3 times as many deaths without all the steps that were taken. But right now, we're not recovered, we're simply stable. In other words, we are seeing a consistent number of new cases, not a rising number of new cases. And our healthcare system can handle that. But to eliminate it, we need to continue this process. And since as so-called flattening the curve also elongates the process, we need to continue it. And we'll do that because remember, these things change us, but I hope it changes us for the better. I hope it changes us toward greatness. We're going to learn what's important. Many of us have already learned the tremendous importance of that extra time that we're able to spend with our families, with our children, which we wouldn't have had otherwise. And many of us have learned that a lot of the things that we used to do weren't so important. So what I want to do is finish this by leaving you with some thoughts about what you do when you think you're doing something that is really, really important, but it's very hard and you're afraid. And what do you do about that? I hung a quote on my door when this started, and I want to read it to people who aren't in my hallway because I think it's very important. It was by a man who faced tremendous demons, tremendous difficulties, and tried to do something that was important to him. And what he said was, I hope to do it better in time. I myself am very far from satisfied with this, but well, getting better must come through doing it and through trying. That was Vincent van Gogh, and his trying was masterpieces. We're never going to be painters, but our masterpiece is the healthcare system. It's taking care of sick people. This is our challenge. We're very good at it, and we will do very well if we do it together. There will be new challenges. I promise you, I will do everything possible to make sure it is fair and it's for the betterment of our patients, our staff. And I'm very proud to be working with you. We're only in the middle of it, but we're doing well. So be patient and be proud of what you do. Thank you. And could you monitor the chat to see if there are questions?
Right. So Dr. Arger-Keenan says, without testing all healthcare professionals, we won't be able to know how many are asymptomatic positives. I think that's more of a comment than a question,
But the point is well taken. We have amassed in this university an ability to test. We are ahead of the curve. We're slightly ahead on personal protective equipment. We're way ahead on ventilators. I have a figure on that here. Yesterday, we used 15 ventilators. We had 113 in reserve. We used something like 60 anesthesia machines and had another 60 in reserve. Testing, we are just now coming above that curve where we can test more and more people. So I am at the forefront of pushing for that so we know where we are. Antibodies will be helpful when they are improved. Right now, testing for acute cases, and you'll see more and more of that. Other questions?
Any other questions?
And feel free to unmute yourself if you want.
So I just have a question. What do you think the, this is from me, but what do you think the return, the gradual return to patient care functions is going to look like?
Yeah, let me start to guess. When this started, I said June. I think that we will be looking a lot better in June, but it's going to spread out longer. What I truly believe will happen is that we will have to win the confidence of our patients that this is a safe place. And we're starting to get that word out. And it'll happen by they first have to be confident to come to their clinic, to see their doctor, to have their chest pain looked into, to have their arm weakness looked into to see if that's a stroke or radiculopathy. I believe that will take us 2 months. And that's only if we maintain a steady or decreasing number of cases. If that peaks, everybody will become very frightened. Second is we have to gradually open up the hospital, and we are doing that now. I again think that will be a 2-month process. And if in that 2 months we were able to greatly decrease the backlog of cases so that we will be in a good shape to take care of the people who will be discovered in the clinics, then I think we're well into July and August where we are seeing ourselves working at 80% capacity, and keeping in reserve that capacity if there's a spike in COVID, and we'll be going on. I honestly think that this will parallel what's done in society, and society will very carefully start to open up so we can do more farming, we can do more food, we can do more simple jobs, but they're going to be changed. The people are going to have to be distanced. There'll be more masks in public until the numbers go down. I do think that I saw the question come by that it will be quite obvious that the way we work will change forever. So many more of our appointments will be telemedicine. I truly think that'll be 30 to 40% of our appointments in the future. There's a lot that surgeons have to do by seeing people and talking to them and seeing films, etc. But a lot can be done by telemedicine, and that's a good thing we learned from this. But just like that, the way we do things will change. Will we be comfortable sitting with 80,000 of our closest friends at a football game in September? I sincerely doubt it. Will that come in years to come? Yes, I do believe that. That was the situation after 1918. It took about a year and a half for people to feel comfortable in crowds again. I think that's going to happen again here.
You know, may not go in the stadium, but I'm going to tailgate.
There you go. But socially distanced.
Just joking.
The best part.
Yeah, it's the best part. One more question from Melissa. Are we going to continue to, making most clinic visits, telemed visits after May 8th?
But what I was implying is that we will transition to have as many televisits as possible. And I predict it will be 30 to 40%, but we will be going from 10% in person to 30 to 40% in person. And then we'll still have people postponed. That gradual transition over the course of the summer will probably settle into something like 60% in person and 30% telemedicine and 10% probably postponed by the end of the summer. That's my guess. I think that's possible, but that 60% we see in September are going to be distanced, and they're going to have particular times and be told when to come in, and they may still be wearing a mask then.
Yeah, I would say that I've been still seeing some patients personally throughout this whole COVID epidemic, and you should just push for seeing people who you would want to see no matter what. So I mean, don't make everybody a telemed visit. Make the appropriate people telemed visits, and then the person that might need procedure, might need more counseling, make sure to see them. I usually put their family who can't come with them on speakerphone so that they can listen in. It makes it reasonable enough to get the points across. But I think it's good to see people in those situations. And then let's see, Amy is asking about the use of video, which is the video consult platform. I will try and answer that. Most of them were trying to transition to video telemed, what would be true telemed, which is video plus sound. The reason that it was supposed to come out this week, but with all the huge announcements on money and salaries and things like that, there's been a lot of slowdown on that rollout, but it's coming along. What's basically happening is that the clinics and the staff, the nurse practitioners and the faculty are going to look through their lists and target patients that may be appropriate for those types of consults. And the key is that the patients have to want to do it. Some of them are just as happy to do it via telephone. And they also will need to have the appropriate equipment, which
that will be the limiting factor. The limiting factor, the reason telemedicine will not take over everything is going to be on the patient side more than anything else. Their equipment and their facility using that equipment will be very variable.
But
I understand.
Yeah, I think that I think it will become more prevalent. So Amy, you'll be seeing a lot more of those coding things, and we'll have to be careful that as Shelley just points out, there are some telemed visits with video scheduled for tomorrow. So yeah, it's this week is when things start to ramp up a little bit, and there are some service lines that have been doing these telemed video visits for longer than us because they've been really piloting the whole process. So so it will come along, and hopefully everybody will learn together.
I want to thank everybody. Appreciate everything you're doing, and thanks again.
Can I ask a question quick, Dr. Demme?
Yeah.
Is there
Yes.
So for those of us who have been in and around the hospital infrequently over the last 6 weeks, are there any things that we, as you know, we start to return to some normalcy here, are there things that we need to keep in mind when we're coming? So I noticed I was there the other day. I didn't know face masks were required in the hospital. So are there things that, you know, that we need to know to prepare ourselves to kind of come back to work when we are going to be able to come back to work?
Right. So
things to know are limited entrances, face masks from your car in and back out to your car. Your temperature will be checked at the door. ID must be shown continuously.
Right. So these are new things as of last week, and I imagine that the emails go to clinical staff, but not to med school and research staff, which comes out in a separate feed. So you'll notice that, and even for me, I didn't happen to read that email, and so I got the same message you probably did, that you should be wearing a mask verbally. For the most part, when the rules are changing, they're being accommodating about it. It's not as if you just get turned around at the door. They usually have some process to get you through.
They actually have masks there for those first few days for just that reason.
Right.
Yeah, so that was a question I got so after going through it, we had a lab meeting yesterday and communicating that with some of our staff. That was a question that they had, whether or not they should go procure their own masks to wear to and from their cars, or if those would be provided. And I said, better to have your own than, yeah.
And I believe from the standpoint of getting in and out of the hospital, you can wear any type of mask, whereas in the hospital, the clinical providers are supposed to wear the masks provided by the hospital.
Yeah, Trost changes to his Halloween mask as he goes out to the car. Thanks again. Appreciate it.
Thanks.